going to talk about trials of change practice in urology, but I'm going to start, for the first half of my talk, giving a little bit of a more general flavour of trials in surgery and why it's difficult to recruit to trials and how we might improve our performance as a body of surgeons within the various specialties. So it's good to start with the definition. Clinical trials are research studies in which people help doctors to find ways to improve healthcare. Each study tries to answer scientific questions and to find better means of prevention, diagnosis and treatment. This is self-evident, we all know this. What we also know is that those people who undertake clinical trials often feel like the bunny under the chair about halfway through the trial and wonder why they've ever started in the first place. Of course, surgeons are historical trialists. The first surgical trial undertaken was by James Lind, 1753, in his trial which showed that scurvy was prevented by the use of vitamin C. Things have become a little more sophisticated, but we've a way to go. This is the view of Richard Horton, still the editor of The Lancet, in an article in 1996, Surgical Research or Comic Opera, highlighting what Lorna has said already, and John has amplified on, which is an over-reliance on case series, insufficient evidence from randomised trials, a large proportion of the surgical literature which is of questionable value. And what we all know is that there are hundreds of testable hypotheses every day which remain untested. This is where we are. This is 2009 surgical trial activity. These are trials that involve any cancer. These are trials that involve surgery, and these are trials that involve surgery and cancer. So, given that cancer is such an important part of surgery, and surgery is such an important part of cancer, this is a pretty small number. If we break that down to recruiting trials in phase 3, the number gets even less, 228 right across the spectrum of surgery, and this is where we are in urology. We have only 20 surgical trials currently ongoing for one of the biggest surgical specialties, covering kidney, bladder, prostate, penile, and testis. And this is one of the problems that, if we look at this article from The Lancet in 2009, which highlights that certain surgical procedures have a tipping point. And that tipping point can be very rapid, and the uptake can be very almost immediate in some techniques, where the surgeon thinks it's better to do it this way, without actually having the evidence. And Laura, you highlighted this, that the technique is picked up first and the trial is done afterwards. And then other techniques which are picked up a little more slowly. And you can apply what's known as Buxton's law to this. It's always too early for rigorous evaluation until, unfortunately, it's suddenly too late. Now, if you look at the diffusion curves for laparoscopic procedures in surgery, this exemplifies the tipping point process. Here we've got cholecystectomy, very rapidly taken up by the surgical fraternity. Can anybody tell me where the randomised trials are? Well, they probably aren't there. If you look at laparoscopic nephrectomy, you can see this has got a much slower tipping point, but it's starting to go now. There are no randomised trials of laparoscopic nephrectomy of any value or any size. One of the things in urology which is currently discussed at every meeting, large numbers of papers and talks on this, robot-assisted laparoscopic prostatectomy. This is the robot of Christie, one of the hospitals that I work. This is Vijay Ramani, one of the urologists who does robotic prostatectomy. We look at the tipping point in relation to prostate laparoscopically with a robot. This is the American figures from 2008, the fourth quarter, and what you can see is that laparoscopic robot-assisted prostatectomy has a very steep tipping point, and currently in 2009, 80% of all the radical prostatectomies in the US were done using a robot. There hasn't been a single controlled trial of robotic versus laparoscopic, or indeed laparoscopic versus open. That data doesn't exist. Now, one other thing that we do in the prostate, and there's no evidence for it really in any kind of level 1 scenario, is freezing the prostate. I want to take you back to 1962. This is Wangenstein. who published in the Journal of the American Medical Association on achieving physiological gastrectomy by gastric freezing. And here are all the trials. This is the Weinstein trial, observational study. That changed practice in the US, so that there were large numbers of gastric freezing techniques carried out on patients until, hidden by that little black rectangle, the first results of a large randomized phase 3 multi-center trial was done, which showed that it didn't work. By that time, 18,000 patients had been treated in the US with gastric freezing. So, I'm going to go for the second part of this talk to the story of androgen deprivation. To cover clinical trials in urology in 15 minutes, I felt was probably a difficult task, and that's been covered well in transplantation and gastric. So I was going to stick to ADT, androgen deprivation therapy, because it's a nice story with a number of good trials and some ongoing and innovative trials currently in the way. This is Charles Huggins. He is the only Nobel Prize winner in urology. And he won the Nobel Prize in 1966 for his work, published in 2 papers, Cancer Research 1941 and Archives of Surgery 1941. These were small trials, about 40 patients in each of these studies. The effect of estrogens and androgen injection on serum phosphatases and metastatic carcinoma of the prostate, and the effect of castration on advanced cancer. The effect of androgens in the prostate has been known since about 1895. But what Huggins did was show that this was applicable in the clinical setting. And so immediately, this was taken up by the worldwide fraternity in the management of advanced prostate cancer. Men were treated with orchidectomy, and then they started to be treated with estrogens. And it wasn't until a classical series of studies, known as the veteran studies, that estrogens were found to have their problems. This is the first Veterans Cooperative Urological Research Group study, which was published in 1973. This was 1,900 patients, so a substantial trial of placebo versus estrogen, orchidectomy placebo, and orchidectomy and estrogen. Now what's clear, if you look at this percentage surviving graph here, is that those patients with just orchidectomy or placebo did worse in cancer-specific terms than those patients receiving estrogen. So, estrogens are better at curing the cancer, but if you look carefully at the data overall in total deaths, you can see the total death rate across the patch is actually the same. And highlighted in red will tell you why, that the estrogens actually were more effective in suppressing the cancer. But the consequence of treating with estrogens was that the cardiovascular death rate was much higher. And subsequent to that, further studies looked at the use of stilbestrol in standard 3 milligram dosage and reduced dosage at 1 milligram. And these are the studies that have looked at this. The cardiovascular toxicity, 30 to 35% with 3 milligrams, and even with 1 milligram, 10 to 20%. So what Byers said, who ran the first veteran study, was that what oral estrogen treatment wins from the cancer, it more than loses to other causes of death. So an excellent phase 3 multi-center randomized trial looking at established practice and coming to the conclusion that that practice actually had its flaws. And so the urological world moved largely to orchidectomy as a treatment of choice. And the next step really was initiated by this man. This is Shelley, who was a biochemist in Belgium, who discovered GnRH analogues. And he published his work in 1982 in the Proceedings of the National Academy of Science. And the major trials in GnRH analogues, which were developed at the AstraZeneca site, which was then ICI Pharmaceuticals in Cheshire, culminated in this study, which was published in 1991 by Amir Kaisari, who was a urologist at the Royal Free here. And you can see very clearly that in a very simple, randomized design, gazerolin versus orchidectomy, in what then was a large trial, but now would be perceived as a relatively small trial. There's no difference between GnRH analog therapy and orchidectomy. The resultant change in surgical practice from this was that almost overnight, surgeons moved from doing orchidectomy as a standard treatment for metastatic prostate cancer to using GnRH analogues. And something like 80–90% of patients at the moment are now treated with GnRH analogues by comparison with what was the case in the 1980s.